What happens if we flip the traditional way of sharing medical information to the wider population on its head? What happens if instead of letting algorithms or the zeitgeist of the moment order our social media feeds, we go straight to the source of clinical medicine and ask practicing experts what they see day in, day out, and give them an unedited platform to help disseminate practical medical information straight from the specialist. So welcome, Jen. What's your surname? Albarak?
It is Albarak, and said correctly. Yeah.
So thank you for coming and joining me in Hackney today.
Thank you for having me.
Taking the afternoon off from your 4 children.
Too many children.
Clinical work at the Whittington.
That's correct, yeah. So I work as an Advanced Physiotherapy Practitioner at the Whittington Health Hospital. I work for a service called the Clinical Assessment and Treatment Service, dealing with musculoskeletal disorders.
No, the reason why I've asked you is because you're the back pain expert. And I don't think that your introduction of yourself really explains how clinically experienced you are when it comes to back pain, but you are a Band 8 physio. What does that mean?
So the Band 8 role is looking at other management options for patients. So if rehab is not succeeding in managing their pain, we're looking at what alternatives there are in terms of treating their lower back pain.
And I think we just touched upon the fact that I work with your husband, but I work with him at Spurs. So I don't know whether you were aware, but I texted him first asking, can you come on my podcast? And do you know what he said? He said no.
No.
My wife's better.
Yeah. Which I'm sure is the case with many couples. But yes, but certainly for spinal pathologies, he is correct. I am better.
Great. So I truly have got the expert. But he's a fabulous clinician, I have to say, because I worked firsthand with him. For a wee while. So thank you, Jen, for coming. So we have done a little bit of prep work just before we've hit record, and you understand the format. And I want to ask you, from a specialist perspective, what 3 things do you want to share? And the first level is with the general population, the second for your GP colleagues, and the third level is for your specialist colleagues. And because we're dealing with, I've imposed this on you, I've asked us to focus on purely back pain, even though you're a musculoskeletal Band 8. I just think it's one of the most commonly misunderstood conditions, and I want to give you a little bit of a story. Hopefully it's more fun than not.
Absolutely.
As to why I thought, no, I need to do a back pain one, even though it's my area of expertise.
Yeah.
So I'll give you this example. I went to a film screening overseas. I have some sort of viral illness. I'm not feeling too great, so I've dragged myself out of bed and I'm knocking a few tequila cocktails back.
So showbiz.
It's an intimate little circle, and we're chatting. And then when they ask me what I do for a living, I'm like a sports and exercise medicine doctor. And at this time I'm thinking, oh my God, I think I've had like 2 or 3 cocktails and I'm not feeling at my best. So I hope this line of questioning doesn't go any further. Oh, of course it does.
It does.
They're wise, experienced, probably live in some fancy city in America.
Plenty of access to healthcare and health experts.
Yeah, for sure. When he asked me about back pain specifically, and I said, oh, well, you can consult with me, because I didn't really want to talk about back pain. He then went on to explain what his chiropractor had said. And of course, you've got to be polite in these situations. And I was smiling and nodding, and I was, and very politely saying, well, I wouldn't explain it that way. And that's as far as I got. And it saddened me that somehow they were led to believe that they've got to stand in a certain way, and actively reminding yourself about posture was a treatment modality. When I don't know whether rehab and strength and conditioning was occurring simultaneously.
And we do unfortunately see these quite a lot, not obviously with the showbiz and the millionaires, but we see this quite commonly on the NHS, and I'm not sure whether that's because there are so many alternatives for patients out there in terms of treatments. There's chiropractors, there's osteopaths, there's physios. There are a lot of health experts that offer their own opinion and have their own
Even
explanations.
PTs, sorry.
Even personal trainers. Yeah, absolutely. And a lot of them have crossover, which is great, but there are some that don't, and so you have these terminologies that the patients are, repeating over and over,
and seeding into their subconscious,
it is.
And that will affect how your body responds as well.
They often say, they feel misaligned, or they've been told they're misaligned, or slightly twisted, and they don't want to reinforce that, so they feel like they need to shift this way, shift that way, or have these corrections, and it's very, very difficult to unravel that perception, that belief within a consultation.
Within a consultation, or I don't even know how helpful it is to unravel that. But then I think if they're coming to me professionally and they're in my consultation room, then I'm going to have to then start with
you can take ownership.
Exactly. Then I'm going to have to undo some preconceptions that may not be serving them very well.
I think, in a social scenario, it's very difficult. But, with this particular very casual consult, so he was obviously being taught to engage his core, but consistently. So throughout the day, he was asking to actively pull it. I mean, that's very difficult to do, and not very.
I switched off. I was just like, I can't smile and nod anymore. Next tequila, please. But I just know that he could rehab better. He could have more muscle.
Yeah. And I think the only barrier that I see in the sort of clinical context is really pain, pain and people's belief of pain. Yeah. So, we have, obviously, in London, the thing that we love the most is that there is such a hugely diverse population. And so people's perception of pain, people's beliefs of pain is very different from patient to patient. There are some patients that feel that pain is an alarm bell and that they should not do any movement. And then there are patients that, feel or certainly can't understand why exercise is not working. They do exercise all the time, and
they're doing too much.
Yeah, I can't say that that's not the common patient that I have, but you do still have them. And they've tried everything. They've been to the chiropractor. They've been to the osteopath. They're now searching, and they just want some relief. Back pain generally, can last, with it being mainly myogenic in nature, so muscular in nature. It's an irritation to the tissue. It's an inflammatory response, and it normally resolves within 6 weeks. Okay.
So are we starting now? Is this your message for the general population?
We want to see those are those patients. They are the 8 out of 10 patients, though, the common occurrence of lower back pain that comes and it resolves and it goes. Okay, and if patients are doing their exercises regularly, in terms of managing the muscles in and around the lower back, then they will find that they can stop those relapses and they can prevent the reoccurrence of their mechanical lower back pain.
Okay, so 80%.
That's 80%.
Often from muscle.
Often from muscle.
And the way I explain it to patients, when you cut your skin and you have a laceration, you can convince yourself, if you're patient enough, it will heal. And you can see it healing. So you can understand the changes. And then that fills you with confidence.
That's right. But with the back, it's a difficult context. It comes, we can't just completely brace it. Every movement you do will require some sort of spinal adjustment, some sort of spinal movement. And so it doesn't get that chance to heal as quickly,
And patients can't convince themselves because they hear
so
of these terrible narratives of this chronic lower back pain that just plagued individuals for decades. So all of these stories have planted seeds and they are worried. And so that's why I'd like to think that they come to me to get some words of reassurance.
Absolutely.
But I really like that stat that 80% are down to muscle. And just to then add to that, so then 80% are maybe microscopic tears within the muscle, and we're trying to retrain other muscles to become stronger, so they're taking over at the right time, and we've got the sequencing correctly, and that's what physiotherapists do.
Absolutely.
Yeah. So you're not loading patients because they've got damaged tissue.
No.
as much as you would be if they were loading when they're training, but you are loading them to try and stimulate new growth.
So the reason they've got those areas of weakness is because those muscles haven't been firing enough. And so we're trying to just target that muscle activity, and we're trying to load them so that, it does excite them, it does activate them, and it does therefore support the skeletal structure, which can be causing it. There are sort of periods of your life where that's more common. We've got a lot more fat versus muscular support, and that imbalance is what can cause
meaning that the not weaker but the less capable muscles are then having to support additional body weight in the form of adipose tissue.
That's right. Adding more compression, and there's less support, there's less
one
strain.
thing that the example that I can't give you the source, especially for city workers or any desk-based work, you're sitting down and your iliopsoas, so that's one of the big muscles, and I describe it's like the loin muscle, is it? If you equate it to pork.
Yes.
Something that runs on the back side of your abdomen. Yeah. And then that will switch off after 20 minutes of sitting down. And so that's why as a doctor or a junior doctor and physios, we're saved from that, because you're having to get the next patient or examine them and sit down, take a call and run around.
You're so lucky.
But for everyone who's stuck at a desk, 20 minutes stand up and then sit down, and that will be enough to keep that firing.
Absolutely, and that's really one of the key messages. Really, is that our bodies are made for movement. We need to keep moving. We need to be interrupting our day every 40 minutes. Just make sure that you are exciting those muscles, you're waking those muscles, and we are giving those joints, those segmental joints in between the vertebra, that little bit of movement that it so craves.
You quote 40 minutes. I'm going to push you for that.
Yeah. So 40 minutes is what we generally ask patients, certainly those that are desk-based patients. We have them setting alarms on their computers sort of every 40 minutes. So it's mainly more to do with the fact that anything less than 40 minutes, they interrupt a function or a task. So it's just a lot. So they normally, it's very much more of a life. Ideally, if we were going with the clinical contest, it would be between 20 and 30 minutes. But what we found through the research,
what I've been quoting all this time,
you're absolutely right. Correct. But we would rather them do some of them than have to hit the alarm and go, no, just ignore it. Right. Then
So I was working from home today. I was getting this setup ready. But even when I'm unloading the dishwasher, a quick squat down to that level to get something from the back, that's useful.
That is very useful.
It's integrating it into...
It is. Basically, the message that we really do need to reinforce is movement is what's going to save people, certainly from lower back pain. Getting up, interrupting your day-to-day sat at a desk posture,
and even if it's one squat,
even if it's just one squat, and
it
can be less than 30 seconds, and it's perfectly executed. It doesn't even have to be perfectly executed. One squat and some lower back stretches, side to side stretches. So when we're saying interrupt, your meeting or interrupt your task every 40 minutes, it's a 30 seconds, which anybody would be able to do.
Nice. Now that I have you here, I'm going to quiz you. So my patients, when I send them to physios, I'm like, so what did you do? Tell me. Like, I need to get an understanding of functionally how they've improved.
Of how that session goes.
I've been stretching. And I'm like, no. I mean, maybe you think they're stretches, but I think they're more complex. But can you explain?
So I think we're trying to move away from the word exercise purely because it seems to evoke a lot of fear in patients. We refer to it more as movements, or the physio might actually refer to it as stretches. But it's trying to contend with sort of patients' perception of, we can't do exercise. But then if you sort of introduce the fact that it's actually just moving your body, but in ways that will...
But technically, what is a stretch?
A stretch is to put a muscle on a lengthened position.
Yeah.
So
for a period of time.
For a period of time. We normally hold it for about 30 seconds.
Okay.
And we repeat it at least 3 times to try and get that.
Right. Will that switch muscle on if we're talking about getting it out of standby?
It will structurally, temporarily lengthen the muscle to decompress the area and therefore give relief.
Okay. So what are activation exercises?
So activation would be to contract a muscle, to shorten a muscle, and to generate power.
Okay, so is that the squat then?
So that would be a squat. Yeah, absolutely. Yeah.
So you can do a combination of both.
Yeah. I mean, ideally what you'd want to do is you'd want to warm up with stretches. Lengthen and get those muscles, so get all the blood flow, rush into those muscles, that muscle group, with stretches, and then obviously then activate the muscles to try and
So this is
generate
whilst
power.
you're working from home, every 40 minutes, do a stretch, do an activation.
Absolutely.
Is that a good enough prescription?
That's a perfect description. Yeah.
Oh, prescription.
I mean, if yeah, prescription. If we even then had like a little video that we could link to it, it'd be even better. But yeah, I'm just really, pushing the fact that it doesn't need to be a lot. That really kind of makes a big difference. So really, it is about sort of interrupting your sedentary job, interrupting that desk-based position that you put yourselves in on a day-to-day basis, and also prioritizing strengthening, prioritizing weights. I know certainly for women, I mean, I can see it in the gym every time I go. There's a definite distinction. The women are over there in the cardio, the men are over there in the weights. And if I could just flip that round, I would have a much lower waiting list on my NHS caseload. The men probably don't need to be pushing the weights that they're doing, certainly don't need to be pushing the weights that they're doing.
So they're exceeding their tissue's capacity because they're just doing a bit too much, too regularly, too whatever.
And then they present with injuries.
And then they're breaking the tissue down.
Absolutely. Women
are perhaps understimulating, underloading, not getting robust enough tissue present in the first place. And then just carrying, a little extra weight perhaps, and then just overloading through underuse.
And then it's sort of collapsing under them, as in, then don't have that stability.
That's a nice way of explaining it. I've never thought about it.
For women, certainly, they think that cardio is going to be what's going to kill the fat and is going to help with the weight loss. And we know through scientific evidence that's
I think socially it's just more acceptable.
Yeah,
because you see everyone running, and I can understand it's a pair of trainers that you need.
Yeah. I think there is sort of a mental health, sort of a well-being, and getting on the road, getting out there, and just sort of switching off. I do see that, but really, if we're talking about trying to prevent, and specifically, obviously, in today's podcast, prevent lower back pain, I need you at home. I need you doing resistance exercises to really tackle this.
Okay. And so resistance training or exercises could even be putting your body weight or using your body weight.
I don't want to use weights. I don't want them to sort of visualize, pushing the heavy pounds.
Like a push-up is a
yes, absolutely.
Exercise,
using
right?
your own body weight. Yeah, absolutely. Doing simple movements that, using your own body weight that would certainly.
Squat, that's another example.
That's it. And lunging. Those are really helpful points. And, the likes of Pilates, it is about engaging sort of the local muscle system, that the smaller muscles that, are not there to push weights. They're not there to pile on the power. They're there just to support and engage, and they're there to sort of generate smaller movements within the spine, in between the vertebra, not just sort of the gross movements that we generally use for function. But without them, that's when sort of dysfunctions develop. That's when disc prolapses, disc deconditioning. That's when that all takes place. And so I think when we're talking specifically about trying to prevent the clinical reoccurrence of lower back pain, we need to make sure that the local muscle system has been addressed, and physios will take patients through the very simple basic exercises to try and target those, and then build on sort of the much more global, bigger muscle groups afterwards. So it's sort of laying the foundation and then building up. So there's definitely a strategy, there's definitely sort of a progression to the rehab, and that's why obviously we have rehab experts.
Okay, thank you. I want to quiz you about imaging, because this is one thing that I want to tackle. As you know, I'm a sports and exercise medicine consultant. I am based in private practice, so maybe I see a type of patient. But I really want to myth bust with you.
There is there is a lot going around in the media about the imaging. I think generally, as a generation, we are tending to over-image, and I think there's many reasons for that.
I can explain from like the 20-year-old, 30-year-old that I'm seeing in private practice.
Yeah.
So they think that everything's covered by insurance anyway. And there's this misconception that either a clinical period of observation or an experienced specialist consultant or a clinical examination or the history in itself don't have value.
That's so.
And that in their eyes, an objective, static, albeit high definition image is going to be more meaningful
The
than
solution
everything
to
that I've just spoken about. And from my perspective, I know that I'm just seeing the beginnings of this, because I think the culture is changing as these individuals who consider themselves well read because of what they're accessing on the internet. They consider themselves educated patients, and they are almost demanding it. Even, and this is why I want to sort of share this, because I'm sure the GPs must get this as well, but they're almost demanding it. And, you know, from my perspective, it doesn't make a difference to my budget. I don't have a budget in private practice. It's their insurance policy. But I still don't want to sort of feed into this somewhat tricky narrative. Then it may set their patient journey up for failure. And this is what I ultimately end up explaining, that if it's going to change my management, I'll definitely order it.
Absolutely.
But if it's not going to change my management, bear with me, because actually all the things that I've listed, and especially the clinical observation period, that is meaningful. And I just wanted to get your take on it, because I know that we work in completely different spheres. But back pain is back pain. And this is why I'm hoping, you know, if people in
still
America
seeing
hear
the same
it,
thing.
India hear
Yeah.
it.
So what we've spoken about so far has been central lower back pain. That 80% of the population will unfortunately experience in their lifetime. That's central low back pain that lasts approximately 6 weeks and resolves itself. But when obviously the pain persists, and it persists longer than 6 weeks, I think GPs certainly are experiencing exactly the same as yourself there. You know, they feel the pressure to escalate. They have the patient in the consult room, they're demanding imaging, and they have the time pressure as well added to that, and they feel the need to refer them on. They have recently changed their MRI policy for our area, and that GPs can only refer for imaging for symptoms, certainly with back pain, that have persisted for more than 6 weeks, and also have referred pain into the legs. That's referred to as radicular pain. So there's sort of a criteria now for
Ridiculous. The layperson, I mean, that's the technical term for sciatica.
That's correct, yeah.
The layperson
So a nerve pain that's been irritated at the back and referring down into the limbs, into the legs.
Okay, thanks for that. So just to also think about it from the patient's perspective. So I'm a patient and I'm thinking, what happens if I have a mass? What happens if it's cancer?
But we would have those signs, and they would have these pickup signs. They're known as red flags.
But this is where again, it's that clinical period of observation. I think, yes, everyone's terrified of cancer. Who isn't? But then it's also knowing that cancers will present in a way that's atypical to a mechanical back pain. And so if all of your symptoms are textbook onset, how it's responding, what I'm finding with my clinical examination, if all of that is textbook and it's ticking all of these boxes, it's a way of practicing clinical medicine, but you're not going to reach for that, oh my God, this is cancer, because everything about it is screaming, it's a duck. So it's a duck.
Yeah, absolutely.
And if you observe the patients, and if the patients will come back to you and say that something's changed, and then you reassess them, that's the more meaningful piece of information.
And it should be, it absolutely should be. But I do think that we're seeing that huge shift. I don't think we're able to reassure the patients as well. I think because there's now much more access freely available to them through the internet, you know, they can obtain images privately. You know, they are taking the autonomy and seeing sort of less importance on that clinical examination.
Yeah, and because they're not. That's not spoken about, the weight of that. But also because the way that emotions work is that you'll remember this tragic story. I'm sure we've all heard of some tragic story. It even affects you as a doctor, but that is inbuilt to human beings for some reason. I'm not going to try to explain it.
There will always be that one story. But when we're dealing with these individual cases, we should be able to reassure the patient through clinical examination, because that is what is most important. When I'm triaging,
and that's why you're going to the clinician.
That's right.
You want them to take over. You want them to look after you, and you want their assessment and almost to compare it to the thousands of assessments that they've done
that
in
we've
lifetime.
done.
I mean,
Absolutely.
really, you're talking about that kind of number.
We would only image obviously if obviously there was a red flag that indicates a cauda equina. We would image if it was going to change our management of this patient.
Something didn't fit into the clinical pattern.
That's
but
right. Things are not improving.
This clinical pattern of low mechanical back pain, it's so bread and butter.
It is, and we always hope that that's the case. We hope that with all patients, that it is a textbook, and things will start to improve if we can just try and keep that patient moving and give them the appropriate analgesia, give them the appropriate anti-inflammatory medication to ease and settle the inflammation, to allow them to maintain movement on a daily basis and return to function. If obviously that is interrupted, if new symptoms have developed, such of weakness in the lower legs, then obviously it will call for a new assessment, and it may need imaging to then reconsider what our management options are.
You gave me a really nice example of demonstrating the budget between Camden and then Islington
and Haringey.
And that helped me understand better why we're talking about ordering imaging appropriately, because it has a knock-on effect that the individuals can sense in their catchment areas.
We do. We have a lot more of a social economic poverty here in Haringey, and that makes a massive impact as to how patients manage their symptoms. There are also the occupations that these patients are doing a lot more sort of manual, lot more, probably put an awful lot more physical pressure on their bodies.
Okay.
But yet we do all still have the same pot at the end of the day. But what we should really be looking at is just making sure that we're not changing what we do in terms of a clinician's management of patients. It's still the same, that we're only ordering imaging when it's indicated, and not really as a way of offering reassurance. We should be able to offer that reassurance with our clinical examination and assessment.
But
of
our
the
words
patient. And our words.
But how does that? Did you give me a stat before about how it impacts?
So the stat was looking at how many of Haringey's population fulfill the complex needs, and it's just over 50% for Haringey. And when we say complex needs, that means patients that are very young and that have multiple comorbidities. Comorbidities being conditions, diseases that require long-term management. The same stat for Camden area is less than 16%. So there's a big difference. 53% versus 16%.
And the money that you're allocated for those two regions is exactly the same, regardless of how complex the needs are of that population.
That's correct.
So then if you add to maybe the back pain talk, that if we can, we could recommend and promote the appropriate requesting of MRIs for lumbar spines. Think of the cost that you'll be saving. And it's not even saving, because patients can tend to latch on thinking, they're getting an economical service. Does that make sense? Yeah, but it's a highly efficient, streamlined service.
It is.
We'll order.
We have criteria for a reason. Yeah, absolutely. And I completely understand. I'm in it. completely understand the pressures that you can feel as a clinician with patients that are also frustrated. The patients are frustrated because their pain is not getting better. So that's
and it's impacting their work.
That's
so if
it,
it's a plumber and they're self-employed,
absolutely.
I completely understand.
Yeah. And
I'm not saying anybody is unreasonable along this.
But we need to sort of offer them that guidance, and I think it's difficult because the NHS doesn't have the availability and it has a long waiting list, so they're not getting that specialist contact very early on. They're having to wait for it. So we do heavily rely on that first contact by the GPs to offer that reassurance and say, look, this is very standard. It's reassuring in that it's mechanical in nature. It's very movement aggravated. What we need to do is we do need to manage that pain with some analgesia, with some appropriate analgesia, and we need to try some gentle exercises. And if they don't have access to an in-house physio, or if there is a long wait, which there currently is for our physiotherapy team, they will be offered a referral through an app called Get You Better that patients can download. We offer it, so when patients are on our waiting list, we send them a letter giving them access to this app, which helps them get started with exercises, appropriate exercises, as early as possible.
Okay, great. Oh, that's something I could use as well.
Yeah, absolutely. And that really is trying to, because like I've mentioned, back pain commonly mechanical back pain lasts for 6 weeks, 6 to 8 weeks.
Yeah, I give up to 3 months for most tissue.
That's exactly what we would give. But, they may be waiting 3 months just to get through to us. So we really do need that. We need to send...
Well, that's why you're here.
Yeah, we just need to send that reassurance.
Yeah,
we need
hopefully
to give them the access as early as possible.
Yeah.
Because I think the wait to them and the fact that it's not getting better, that's what scares them. However, if we could get them seen earlier, then we'd be able to offer that reassurance earlier, and then they wouldn't have that guarded posture, that fear of movement. Which
you talk about mechanical back pain. What other types of back pain are there?
So there are other types in that there can be persistent back pain, and persistent in that it can be very much centrally located within the lower back, and that can be caused by arthritic changes within the facet joints. That's degenerative changes in the joints of the spine of the vertebra, and there can also be some changes, some modic changes in and around the vertebra itself. So modic changes are inflammatory responses in and around the vertebra itself. There is very little evidence to suggest the disc itself can generate any pain. Discs can degenerate. There can be some internal derangement of the disc in that it can bulge or it can prolapse, but the discs cannot slip and they cannot move. They can just become less fluid filled. We see that on the MRIs. As we get older, we do start to see some dehydration of the disc. In that case, obviously, they start to become a little bit worn, a little bit thinner, moving the vertebra together and therefore increasing the risk of irritating the nerves as they exit the spine. And then obviously, when they degenerate, they obviously increase the risk of these prolapses occurring.
Wait, so you're not classifying this as a mechanical back pain?
No, this would be you can have some discogenic pain that is still mechanical in nature and still can certainly resolve within a 3-month period, but it's the pain that lasts obviously over that 3 months that either comes with leg pain. Or it comes with leg pain and change in neurology. And when I refer to neurology, I'm talking about the strength and the power in the limbs. So that pain would be called a radicular pain. So that's a pain in the lower back that now affects the nerves as they exit the spine and it refers down into the limb. And that pain can be offered alternative forms of management, but it's a sciatic pain that has not resolved within that 3-month period. Even if patients attended our consultation and they had persistent back pain with leg symptoms, I would still not want to immediately refer them for imaging, because without the symptoms of lower limb weakness it's not going to change the management that I'm offering that patient.
So I screen lower limb weakness very quickly by asking them to tiptoe walk and heel walk. And I ask my patients to keep an eye on it.
Yeah.
So every morning when you wake up, do that.
On your toes.
Yeah, on your toes and on your heels. And if it feels different, one side to the other, come back and see me within the week. Because then I might do something. Yeah. But otherwise, I won't do much. Maybe I've sort of oversimplified things when I explain things to patients, but I just say there are two types of back pain. Mechanical, but that is different from an inflammatory back pain. And the inflammatory back pain is when you've got these predisposing genetics or conditions like ulcerative colitis, Crohn's, psoriasis. And that just means that the type of back pain you have just presents slightly differently. It's more stiff, it's really achy.
Episodic.
Yeah, episodic.
Early hours of the morning.
Yeah, exactly. Yeah. And then those, again, the foundations of the treatment are the same. Physio, anti-inflammatories, in my case, COX-2 inhibitor, and they respond very well. And those are the foundations. So imaging can sometimes, and bloods can delineate between the two, but even when we're dealing with those two types of back pain, broadly speaking, my management in the first instance isn't going to change. So if you are lucky enough to have insurance and you can see a clinician quite early on, 6 weeks, we want to start some of these therapies and see how you respond. And it's your response to the treatment, because the treatment's bespoke to the individual. We're not reading an algorithm. And then I'm going to titrate the treatment plan according to your unique needs. Yeah. And so that's hopefully right. I'm not oversimplifying
no, absolutely.
things to my
No.
patients.
I think sometimes oversimplifying things and then is definitely the way to send those messages. The only thing we'd added, if obviously it is presenting a little bit more inflammatory in nature, we would probably investigate a little bit sooner.
So you'd get the bloods correct.
We would.
I get my bloods, so I get the vitamin D level anyway.
And the reason that I would be investigating was whether, because the role that I'm doing, I need them to be seen by the rheumatologist, and those investigations would identify if obviously further management's going to be needed. Yeah. But it's really just where we are in terms of sort of in between the primary care and the secondary care is we're sort of the buffer. And so we will sort of screen patients.
Sort of a gatekeeper.
Yes, that's right. Yeah. We then want to make sure that they go in the correct gate. Yeah. So at our level, we're screening and seeing whether or not this patient we're happy and that they're doing the right management and they're on the conservative route and that they need to continue with physio, or whether or not we need to escalate them. But what really the key thing is that, because we also triage for GPs, so they refer to secondary care and we'll triage those referrals and make sure, again, they go in the right column, they go in the right service. But what we're seeing, what we really kind of need to highlight in those referrals is that what's really important is the clinical picture, is the presentation of the patient. How long have they had their symptoms? Whereabouts is their pain? Does it refer in the lower back?
Hang on a second. We moved on to our second question.
Yeah. Well, we can do. It's the clinical picture of that patient, how the symptoms are behaving. Have they got central back pain, or are we talking back pain and leg pain? Yeah. And what is their neurology? Do they have full power in their limbs? Do they have full sensation in their limbs? And that again, we sometimes don't always get. So
when you're receiving referrals from your GPs and you need to understand how you're going to triage them. Yeah. So you have a rheumatologist.
We have orthopedics, spinal orthopedics. And we have pain services. Okay. We also have physio. So we need to decide whether or not this is a lower back pain patient that needs conservative management and needs to give a little bit of help with exercise. Yeah. And they would just be that simple lower back pain patient, or whether those symptoms have persisted for such a long time, over 3 months. Yeah. And they may have some limb weakness, or they may have sensory disturbance. Those patients would come to ourselves in the musculoskeletal assessment and treatment clinic.
Okay, so even with limb service, you're not sending them straight to
No, spinal orthopedics. We are very, very lucky at the Whittington that we have an extremely good connection with our spinal orthopedic team. We have multidisciplinary team meetings. So if obviously they come to us, we will discuss with them and then we move them on.
So it's not that they're not gaining access
behind
the
scenes. They have it behind the scenes. It's just our way of consuming
the
the number of referrals we get.
Okay. So that brings us on nicely to what would you like to share with your GP colleagues? And it really is that whatever's on the referral letter is key. And I'm going to be GP's advocate or devil's advocate. If you've only got 3 minutes to do a clinical examination, what do you want from me?
Generous for what they get. I mean, it takes
it takes a minute and a half for the patient to undress. By the way,
that's very true. Very true. But I just want to know, are they able to walk into that clinic room? Okay. Are they able to walk in without a limp? And what was their power? Did they have weakness in one leg? Did they have weakness in both legs? Okay. What was the neurological examination?
Okay. Do reflexes, are those useful?
Yeah. But I mean, you can put those in, but they're not what's gonna disseminate to where that patient goes.
And then the soft touch sensation, vibration. Do you want those?
Sensory again. It's again useful because it tells us whether there is a neural irritation in the lower back or whether or not it's a sort of a myogenic and muscle irritation. But again, it's not going to change where this patient goes. It's really about trying to identify on that referral form they've got one appointment and they've got one waiting list. Where are they most appropriately seen? Okay. And so it is, like I said,
is the power is the big one for me.
If it's central low back pain, they are very appropriately managed with exercise therapy and the correct analgesia. Yeah. If it's lower back and leg pain, then it's something that we can assess and we can review if it's been persistent over 3 months in the musculoskeletal clinic with a specialist, and then we'll decide whether or not imaging would be appropriate or wouldn't be appropriate. Okay, great. But if obviously there is limb weakness, then that's something that we'd need to be seen a little bit more urgently. And we'll image it. We'll definitely image if it hasn't already been done, so that it may actually change our management of that patient. Yeah.
My patients laugh at me because I'm super speedy with my examination, but it's because I like doing all of it. So I don't like, it's not that you're cutting corners, it's just that the more you do all of it, the more sensitive you are for picking things up when it's not normal.
The subjective,
so you're just training the brain, really.
Yeah.
But do you know one thing that I don't do is the straight leg raise.
Am I
doing the right thing by cutting that out?
Straight leg raise we can do without.
Information.
Neural sensitivity is it's not.
The patient tells me they've got sciatica. I believe them. Why do I need to do the straight leg?
Yeah, absolutely.
I do power. I do soft touch sensation, but those you can do very quickly. Yeah. And so my advice for trainee GPs or other junior doctors is actually, when you're older, you can cut corners. Yeah. But I think when you're earlier on in your training,
do it all.
Because the quicker you get at it, it's really great for postgraduate examinations because it will just become like brainstem function. You won't even think about it actively, you'll just do it. And then what the beauty of it is, when you do it all the time, you'll pick up, it's like reading a chest x-ray. Suddenly you'll be able to pick up all of these really small differences. And reflexes is one of those things. So the other reflex I do, which isn't commonly taught, hamstring, L5, that's quite useful as well.
Yeah, absolutely. If you're thinking it was an L5 pathology, for sure.
Yeah. So if I've done midline tenderness and then I've sort of located it, I've also done lumbar flexion and extension. Doesn't really add that much apart from, it's painful. What does reveal a lot is lateral flexion of the lumbar spine. Yes. So your hands on the side of your thighs and they're touching to go as far down as your knees or even further if they can. Yep. That for me reveals whether there's hinging at any point. And often there is hinging just above where the pathology is, because the body's trying to protect that painful segment.
Yep.
And so it's sort of not moving lower down, and it's hinging.
So your side flexion generally comes from the upper lumbar.
Flexion. Yeah, exactly.
Absolutely.
And so I note that hinging. So that is useful for me. Yeah. Tenderness on palpation at a level. So you your hip bones, L4, and then you bisect across, and that's L4, and then you can roughly calculate where those levels are. And then I'll go for the power of the heel walking and the tiptoe walking.
Excellent.
So you can speed things up once you become once you're of a certain level.
Absolutely. And with any of that, did you need imaging?
Yeah, no. But
No.
Thanks for reassuring me.
No, we don't. We take it with a very small pinch of salt. You know,
Yeah.
it's always good if you're thinking it's going to change our management, and I'm going to make that referral to secondary care, to the clinical, to the spinal orthopedics or the pain team. We have to have imaging, and it has to match with our diagnosis.
So
of the
why
clinical
do the
examination.
patients want to cling on to this more sort of in their eyes objective
I think they need
measure?
the visual reassurance. You know, I think, you know, like you said with the elbow scenario, you know, they can see it healing, you know, they're reassured as they see it improve. And with back pain, you know, there is nothing. You can't see anything when you're examining it, and so they feel that
They can't see anything, sorry, but you can see things.
No.
Yeah.
It's still a sort of mystery. It has an awful lot of emotion around back pain, and I think, you know, when you can't get relief, you know, when you can't stop using a limb to help it heal, and you're in constant pain, I think that pain will ultimately it sort of nibbles away at your patience, at your personality, and you know, they can actually transform somebody from somebody being proactive and, you know, able to function on a day-to-day to somebody sleep deprived and just very irritable, and so you can understand why they're desperately clinging for a solution, but ultimately, you know, like I said, we see these patients day in, day out, and the reassurance really should be coming from that.
And the reassurance that we're not trying to withhold something.
We're certainly not. No, we are certainly not.
Yeah. Our priority ultimately is still the individual patient in front of us,
and it's trying to get them better as quickly as possible. You know, ultimately that is what every clinician's trying to do: gain them some relief as quickly as possible. And so making sure that, you know, we receive the correct information from the first contact, and then we can prioritize this patient correctly in the right team, and get them the assessment that they need, and get them the management that's indicated as quickly as possible.
Thanks for explaining.
So sometimes the use of nerve suppressant medication helps when pain is being referred down the leg.
This is your sciatica pain.
That's
or
your
your
sciatic pain. Yeah, your radicular pain.
synonyms.
Yeah. So that would be indicated not for patients suffering with central lower back pain, but for patients suffering with lower back pain and obviously the leg symptoms, the sciatic pain. And that sometimes is very useful to help patients sleep. That's where I was leading with that. You know, when I was talking about the irritable, the sleep deprived patient, you know, it is very helpful to have that prescription. And so sometimes we do ask the GPs to trial a course of the nerve suppressant medication to help with that. That's like anatriptyline and gabapentin and pregabalin. And that's also the aim, the pure aim with that is to better pain manage so that patients can then move
and engage with physio.
Absolutely. Engage with exercise.
Where the more healing is going to occur, you're going to accelerate that healing.
That's it.
I may see patients at an earlier stage, but with a good course of anti-inflammatories in the acute stages.
That's it.
Often that'll be enough to just alleviate some of whatever's touching the nerve and creating, because ultimately why are you getting radicular symptoms or sciatica is because some tissue, inflamed tissue, is touching a nerve. And so if you give a good course of anti-inflammatories, or at least trial it, that often is enough to get rid of the sciatica. So I rarely go on to use any neuropathic agents, but that may be because I'm seeing patients earlier.
Yeah, and I think that's probably the big change that I've seen just in the last 5 years in working in this role, is that chronicity has started to become a much bigger thing, that patients are...
And so definitely, sorry, for those patients 3 months
that's
on
right.
with still these symptoms, I definitely think it would be nice to at least trial them on these neuropathic agents for sure, because then you can trial a short course of anti-inflammatories, 7 days, 10 days, 14 days. That's about it. I wouldn't go any further. If they're going to respond to anti-inflammatories, that's your time frame. And thereafter, then I'd start the neuropathic agents. Are you in agreement?
Okay, good. that's the only sort of requests we make. We're really trying to work alongside the GPs and trying to support.
Yeah, and continue that professional development between colleagues.
Absolutely.
And I love how you phrase that, because often in popular media I'm hearing, well, the GPs or doctors need to be trained. And you're thinking, I don't know whether that's sending the right... firstly, it's not accurate, okay? Because what does that make you think? That this individual does not have any idea? That is not true. No. It may be true that they had one lecture at medical school, but your education doesn't finish at medical school. That's, in fact, it doesn't even start at medical school, right. I think, in my professional experience. Everything starts when you become a doctor. And it's a continued professional development. So it's a real bugbear of mine. When I hear it, it's so patronising. And just really, rather than telling them off, but also to highlight your language use, which was to support.
It is support. Yeah, it is the only way. I think all of my clinical development has been working with colleagues, such as the MDTs, the multidisciplinary team meetings that we have with consultants. All of your learning and your development happens in those interactions.
And it's appreciating that we're all now becoming subspecialists in something, and then how can we share our knowledge with the other person? It's not that the other doctors need to be trained; it's that they haven't a clue about this. No. It's just, what are the shortcuts I can give you?
Yeah, absolutely. It's what we see day in, day out. Whereas they have a huge eclectic mix of different conditions that they're seeing.
But that's what professional life is as a doctor, and I presume other healthcare, allied healthcare professionals, is just sharing top tips.
Yeah,
that's what we mean,
and that's ultimately what we're all trying to work
efficiencies.
towards. Efficiency. It's trying to work towards clinical efficiency.
Can I just drop as well that I've worked in many industries now. Military, in elite sport, in private practice, in the NHS. And so when you hear that the NHS needs to improve its efficiencies, out of all of those industries that I've worked in, the most efficient system I've ever worked in is the NHS.
That is very kind. I work in an extremely proactive team, and we're always trying to work to strive to improve and strive to offer patients more. We try and train
it's
up.
Just that the budgets are quite small.
It is. That's constantly the challenge. Yeah. But it doesn't cost anything to be able to be approachable for colleagues. But it was really just sort of talking about alternative management options that we have for the patients that do have persistent lower back pain. That is not resolving with that conservative approach.
So over 3 months.
Over 3 months, and often enough, to be fair, by the time they get to us, it's almost a year.
Okay, and still just the lower back pain, or the lower back pain and the leg symptoms?
So there are two avenues. Those that are just presenting with the lower back pain, we'll image and we'll be looking for sort of modic type changes, so degenerative changes within the spine.
That's an MRI finding.
And that's an MRI, yeah. We can also categorise what's active inflammatory change and non-active inflammatory change with a CT spec. But we'll be looking to see whether that'll be an appropriate referral for interventional pain management
under the pain consultant.
Under the pain consultant, absolutely, yeah. And they're offering some very exciting treatments at the moment. Depending on whether that pain is generated into extension, leaning backwards, or flexion, leaning forwards, very much depends on what pain management option would be appropriate for them. But the two options we have are medial branch blocks. They would be blocking the nerve that innervates the facet joint. And those facet joints can generate quite a lot of pain, certainly as they become degenerative and arthritic.
Yeah, and that's pain on extension.
Okay. That's correct, yeah. And then for the flexion generated pain, that's a basal vertebral nerve ablation therapy. That's radio ablation therapy, and that's done targeting the end plates where the inflammatory changes happen. And we most commonly see those with patients that are generating pain into flexion.
So this is an intervention that you're excited about and you want to share with us.
I am very excited about it, because ultimately it's able to target the patient population that my physiotherapy can't seem to work with.
Okay.
So when patients are in constant pain, they're not able to comply with exercise as well, and therefore not get as much from it. And in using this type of treatment, it allows those inflammatory modic changes to be suppressed, and for patients to therefore have more pain relief and therefore be able to comply a lot better with exercise therapy. These patient population, it's a huge breakthrough, and we are getting very excited about it. But it's able to sort of tap into that patient population that we've just not been successful with so far.
So I remember, and so this is for modic type 1 changes that you see on MRI. So it was 2013. They got really excited about type 1 modic changes and prolonged antibiotic courses. It's a 6-month therapy. Did you hear about this, or were you practicing this?
Yes, we did. We did practice this, but it was a very short-lived practice.
So you were doing this at the Whittington?
We were doing this at the Whittington.
So why did you stop?
It wasn't effective.
Okay, so even though this was like a seminal paper,
it just didn't.
And we got so excited about it as doctors.
Yeah. I think we were all very excited about it. But as with everything, it's always reviewed and audited, and
when you actually put it into clinical practice,
we just didn't see the outcomes that we
you were hoping
were
for.
expecting.
So that type of therapy, 6 months of antibiotics, did not deliver the type of changes that you're seeing with this new therapy.
That's correct. Yeah.
Okay. So you've been that one. And then now,
that one, but now we're probably about a year into practicing with the
great
with the basal vertebral.
Are you one of the only centres that do this?
We're not the only centre. I think it's practiced a lot more privately, but our pain consultants have been practicing it since March last year, and we are seeing very positive outcomes.
And even without the stats, you're just saying, even if I was to measure it by eye, it's a drastic change.
It is a drastic change,
of being able to take a patient out of this pain cycle,
and
then be able to progress them and load them, and then get them.
And obviously, still piping the fact that they still need to do the hard work, they still need to do the rehab to prevent obviously the reoccurrence. But like I said, it's very important with all of these patients, these spinal patients, that we get the correct pain relief to get them on board.
So maybe I can invite Dr. Basal Al-Hamidi.
He would, I'm sure, be delighted, and he's just incredible, you know, in what he offers the Whittington. It's really is a fantastic service he runs.
Yeah, he wouldn't be there if he didn't have the support of all of you guys as well, and that's why it's just a wonderful ecosystem. So thank you for coming, and thank you for explaining back pain and helping me understand actually how it is a really common presenting complaint, but actually that the ecosystem does exist within the NHS to be able to manage.
We really we understand it very well, and we have all the correct pathways in place, and we operate a very seamless service. So my message is just please be confident in us, and we certainly know what we're doing.
Thank you
ever so much. Thank you for having me.